Well, first of all, thanks very much for inviting me. And I'd first like to acknowledge the Wurundjeri people of the Kulin Nation, and they're the people who've been on this land for thousands of years, and I pay my respects to their elders past and present. I'm speaking as a clinician and not a scientist, so there won't be a lot of fancy overheads, and there's nothing about chromosomes. Although I know a little bit about that, and it does form the basis of a lot of our clinic, but I'll just give a background of what we've been doing at the Children's Hospital over the last 20 or so years. I'm not quite sure how to... Sorry. Oh, it's these arrows. So, beg your pardon. Right. So I thought what we've based our clinic on, and being a paediatrician who spent most of my time, apart from general paediatrics, thinking about developmental issues, I want to just give a background on the developmental approach and how we look at that and how that's informed how we do the clinic. And I'll just then give you a few brief details of what's happened and some of the medical things that we've found out about it. Now, first of all, not all children with Prader-Willi syndrome are different, and they all come from different families, and they share from their parents all their parents' genes except for the bit that they're missing. So I think we just really need to understand that every child comes into a different place, and certainly from a clinical point of view, every child that I see is different, and every family is different. And on top of that, every family and every child's different each time I see them, because there's always things that happen in people's lives, and that helps form the child. In medicine, and I've learnt a lot from the WHO definitions, which are a lot more complicated now, but in the early 80s it was a very simple definition, which I find still very useful. Impairment relates to the physiological function of the child. It could be the chromosomes, it could be the floppy muscles, it could be the brain not firing off well. Disability is what the child experiences. Handicap is what happens when that child with that disability at that point in time experiences with the environment. So for the young child who has just been born and is very floppy, and on day 3 the doctor comes in and says, your child has Prader-Willi syndrome, that child is taking a long time to focus, taking a long time to mouth, to reach the breast. But on top of that, the mother isn't looking, perhaps, or she's got a lot of sadness. So there's a double, that's where the handicap is. It's not just with the child. And how we reduce the handicapping effects for the child is working with both the child and the family and everyone. And that's what informs early intervention, and that's what informs our approach to children with disabilities, and it's what informs our approach to all children who come to the hospital or come into the consulting room with a difficulty. The other part, which is terribly important, and I think I won't go into a lot of detail because we really had a whole morning of it, was what determines us as adults is what some people talk about, our emotional IQ, but it's whether we can adapt and what our emotional life is. And Erickson talked very clearly about emotional development, and it starts with attachment. And we'll talk a little bit about emotional development. The other areas of development that are important are language, and for the very early child, language and cognition are together, because that infant who's using reflexes to mooch around to find the breast, that's language, that's communication, that's the beginnings of it. And then we talk about motor development, which is when we're moving our bodies and when we're using our hands. Now, all those areas of development can be affected, and then they'll affect and handicap the future development, and we heard a lot about that this morning. In infancy, and these are the Erickson emotional tasks, and all of us go through all of these tasks to get to adult life. And it's looking very closely at these tasks to help the child. And certainly I know when I see young infants, it's helping the mothers and the fathers know to hang in there with that gaze and not turn away because the child hasn't smiled. Because guess what? After about 10 minutes, there's a little bit of a smile just creeps around the corner. And it's because the child doesn't want to smile or doesn't know how to, but the jolly muscles are just so weak. So we just have to give time. And that's so important. And it's important that parents are able to say that to grandmothers and to the lady at the supermarket who wants to move on to the next person. But it's letting time and the child have the time to not just process but to move the muscles. The oral feeding can be quite difficult, and some babies suck well, and I think we've had one patient in our clinic who took 12 months to get off the nasogastric tube. So it's very variable, and it's very hard to make any predictions for a family as to how long that nasogastric tube's going to be in if it's in. One area that is a huge difficulty, and I feel as if I'm talking to the experts and you know more about this than I do, is when you get to the toddler stage, if you had good attachment and trust, the child is now learning to take control of themselves. And the toddlers who have good language skills will say, "I am." And that's a very important emotional developmental stage. The difficulty is knowing whether it's the tantrums coming in or whether this is just a normal thing that's happening to the development of the child. When the child gets to preschool, it is learning how to do tasks, learning how to enjoy other children and to do tasks, to be competent in cutting or getting the plate off the table. It's really doing those things. And then in school, it's the experience of success. And these are all tasks that need to be experienced by all children, even those children with Prader-Willi syndrome, for them to be happy, healthy adults. So just to go back to the development of the clinic, and it's really, I think, might be useful for some professionals who are thinking about setting up clinics, but usually in big public hospitals, there's no extra money for anything, so everything's done in existing resources. It's very rare to get a CEO to say, "Oh, well, here's the money to set up a clinic." That just doesn't happen, and it's certainly not going to happen in the future. Okay, so we started off in the 1980s, and then with the advent of DNA methylation, we started the infant clinic, because all of a sudden we had infants coming into the clinic with their mothers. It was off-site, and I think that was a reflection of the times. In the 80s, we were only just getting the principles of normalisation. Institutions were closing. We had the International Year of Disability, and differences weren't treated as the other so much. So there were a lot of changes going on at that time. We've had different staff over the years. And we've had teenage group sessions. We've had groups with information before the clinic. And then in 2009, we've had growth hormone. We've got endocrinologists, myself and another paediatrician working in the clinic, dietitian, social worker, researcher, and because we're a large tertiary hospital, we have access to all the other subspecialists. They don't come to the clinic, and the clinic's held 4 times a year. The sleep studies are done by Gillian Nixon's unit at Monash. We've got about 63 patients coming to the clinic regularly, and we've got a register, and some of the data from that was quoted yesterday in the papers, and there's a poster outside. About 30%, in spite of all this, of our patients become obese by adolescence. About 10% of our patients have scoliosis that require surgery, and about 10% are having braces. About 30% of the patients have had seen by the eye doctors for problems of squints. And one of the registrars has just looked at the figures for the orchidopectocies for the undercentered testes, and we've just found out that that operation's not as successful in this group of children as it is in other groups. So I think I'll finish it there, and if people want to ask questions, they can. Thank you.